All right, so what we're going to talk about now are patient scenarios. I gave you 4 patient scenarios. I posted them on Blackboard. These 4 patient scenarios typically would have been what's known as your practical exam in this semester. We are not doing a graded practical exam, so you guys can take a deep breath on that. But we will still review these scenarios because these scenarios are really, really good examples of what you might encounter in a clinic. And these scenarios will tie into next semester scenarios where you will have a practical. So remember, this semester, we want you to be able to just follow a plan. So you're going to look at these scenarios, figure out the scenario, be able to do what it says, and just do it. Next semester, you're going to get a plan like that. And instead of just doing the plan, you're going to have to do what, do you think? Not just do it, but progress it. There you go. Good, right? Implement and progress, right? You have to look at them and go, okay, how would I progress this patient? Now, the good news is next semester, it will tell you what to progress. You're not going to have to pick something. So if Diana's looking at her, scenario for next semester, it'll say, add this exercise. It's not like she has to pick an exercise, right? It'll say to add this exercise in the note. And then she just has to do it. That's the scenarios for next semester. This semester is just literally look at what it says and do what it says. So I'm going to bring up the first scenario. And you guys will see quickly. Okay, is that what I want? Okay. Let's get to do screens. I don't know why it's letting me share apps. All right, so we got this brought up. I'm going to take away and just bring my camera up. So it's not that I don't want to see you guys, but I just try to keep you guys out of the recorded lecture because I figured that's something you guys kind of want for a little privacy. So we're going to look at the first scenario here. So our first scenario is Miss Laura Lance. And yes, Mr. McKeever wrote most of these scenarios. You can tell that very easily by their names. And if you don't know who Laura Lance is, I'm sorry. I know who Laura Lance is, so it is what it is. It is a Green Arrow reference, you're 100%. Laura Lance is the Black Canary. So Laura Lance is a 61-year-old female. So the way we're going to work through this right now, we're going to talk through this as a group. And then on Thursday when we get together, I'm going to divide you guys up into 4 groups. And then you're going to talk amongst your group and come back and kind of present an attack plan for this patient. So we're going to hit kind of the high level today and then kind of hit the micro level on Thursday. So patient is 61-year-old who is status post, left total knee replacement being seen in the outpatient setting. So now that you know she's in the outpatient setting, what stage of recovery she's probably in?
Return to function?
Return to function, right? So what gives you the clue to return to function? That's okay, Raquel. That's why I'm asking this.
She can get to and from treatment.
Right. And there's another thing that clues you into that.
6 weeks.
6 weeks. There we go. Good. Right. Good. So her active concerns, I apologize, my throat's a little scratchy today. Your active concerns are she has left knee extension lag. What does that mean?
That it's within 5 degrees of normal.
5 to 10. Yeah, close, right? It just means she can't fully do what?
Extend.
Yeah, she doesn't have full extension. Good. Right? She is non-weight bearing on that left lower extremity. Okay, well that may lead to that extension lag, right? Because she can't weight bear on it. The doc says can't weight bear on it, so we got to do what we got to do. She has generalized left knee weakness. Well, duh. Right, and these are things you're going to see on evals. And this is kind of looking at the eval. Then we have a note, and then we have a flow sheet. Or we have flow sheet, then we have a note. Lack of normal mobility, inability to perform ADLs. Right, so these are what she says are some of her problems with PT notes and some of her problems. She also has non-adherence to her prescribed meds. Well, that makes sense. Most patients over 60 don't take their meds right anyway. What's PMH mean?
That's
Medical history.
Good, right? So previously, she's had a knee arthroscopy in '94. So a little while ago, she had her knee scoped. And you'll see this. Most patients that end up getting a knee replacement at some point in their life have probably had an arthroscopy. And she does have chronic low back pain without radicular pain, meaning there's no pain going down her leg, it's just in her back. So let's take a look at her patient history here. It's her social history. She's very social. She resides with her husband in a single family second floor apartment. Patient has 16 steps without a landing to get in her apartment. Patient reports no other major complaints at the time of eval. She reports compliance with her home exercise PT or home exercise program as issued by the home health PT. Patient has been made non-weight bearing on left lower extremity 6 weeks post-surgery. And so maybe you guys are going, well, why is she non-weight bearing? Well, it might be the type of cement they used. And maybe this cement requires her to be non-weight bearing for a certain period of time. That happens. Usually those are like 8 to 10 weeks that they'll be non-weight bearing to allow that cement to set. All right, so looking at her social history, anything that brings up any red flags for you?
Steps.
Good steps, good.
Also like the
Yeah,
non-weight
non-weight
bearing, I
bearing.
think is an issue.
Yeah, right. Especially going up 16 steps. That's not going to be fun, right? Good news is it says that she has a husband. So we know that she has what at home? Hopefully.
Help.
Help.
Yeah.
Yeah, caregiver help, right? She has some help at home. All right. So let's go down because this is literally what some of your evals are going to look like. And if you guys haven't looked at an eval, this is kind of what they're going to look like. I'm actually going to make that just a little smaller. Can you guys still read that effectively? If I make it a little bit smaller like that, or was bigger better?
We can read it.
Okay. So tone is normal bilaterally. Just means she's not spastic, she's not flaccid. That's really all that means. That doesn't tell us a lot. That just means we don't have any flaccidity or spasticity. All right, pain. Left superior knee, constant throbbing and aching. That makes sense for surgery, doesn't it? Yeah, I mean, kind of. Her worst is a 7 out of 10. Her best is a 1 out of 10. Currently at this eval time, she was 3 out of 10. Not bad. So range of motion. Left knee is 10 to 100 degrees with empty end feel. So like Riley said, she's got some extension lag, right? She's about 10 degrees off of 0. So that's her passively. But let's look at her active, 15 to 90. Now, does she have enough to go up and down stairs?
Yes.
Yeah,
Yes.
she has enough to clear that foot for going up and down stairs. Good, right? And the question I've gotten here before is, well, Mr. McKeever, she's non-weight bearing. How did you have her actively contract her knee? I've had that before. And I'm like, well, she's not contracting the knee in a weight bearing stance. We're actually just measuring her range of motion. So she's not weight bearing on it at that time. All other goniometric measurements within normal limits means her hip's okay, her ankle's okay, stuff like that. Left knee extension and left knee flexion, 2- out of 5. What does 2- out of 5 mean?
For manual muscle testing.
Mhm.
Partial when the gravity is removed.
You're closer. You're partially right.
With 2-, right? Oh,
2-.
so
Oh, no, you're right. Okay, I'm sorry. 2-. You're correct. Partial and gravity is removed. You're correct. I'm sorry. I thought this was 2+. My bad. I'm sleepy. Blame it on that.
okay.
Yes. So partial with gravity removed. So for knee flexion and knee extension, what is gravity eliminated or gravity removed positioning?
Sideline.
Sideline.
Right, because it occurs in the what plane?
Sagittal.
Sagittal. Good, right? Right knee normal, right within normal limits. We got some girth measurements here. Oh boy. Now you did some of these last semester, right? A little bit, right? A little bit of girth measurements in Dr. O'Neill's class,
Yeah.
right? Okay. So how do you find mid patella?
You start with the apex of the patella, and there's some measuring like above and below the knee, I believe.
Okay.
I think 2 inches below and 2 inches above.
Okay, that's technically what 5 centimeters is, right? It's about 2 inches. Good. Right? So to find mid patella, first you have to find the apex, right? Which is that bottom portion. Then you have to find the superior border, right? And then you just measure the distance between that and mark your spot in the middle of the patella. Does that make sense? That finds your mid patella area. So you kind of sweep up from the bottom, find that apex, sweep down from the top, find the superior border, measure your distance between the apex and the superior border and kind of split the difference. So if it's like, usually it's about 3 centimeters is usually what most patellas are. They're kind of tiny. You go, oh, well, about 1.5 centimeters is my mid patella. I put a mark there. That's my mid patella measurement. And this one says 5 centimeters above and 5 centimeters below. So I'm going to go from that mid patella, measure 5 centimeters down, put a mark, go to my superior area, 5 centimeters, put a mark. And there's where I'm going to take my girth measurements, my round measurements around the knee. Now, just as a technical term here, because we're measuring 5 centimeters above, which is only about 2 inches, and 5 centimeters below, which is only about 2 inches, we're measuring at that point for true swelling. And the reason for that is we're not getting down into the girth of either the gastroc or the girth of the quads. We're not going up high enough into the quads. We're not going down far enough into the gastrocs. If this said, say something like, I don't know, 4 inches above, about 10 centimeters, or 4 inches below, now we're getting into the girth of the muscles. So now we're actually trying to measure maybe a little bit of hypertrophy and atrophy. Does that make sense to everybody? Does everyone understand what I'm saying? So like if I draw my little patella here. So here's my patella. And it kind of is triangular. There's my mid patella. If I go 2 inches or about 5 centimeters above and below, those are for true swelling. True edema, we'll just call it. If I'm up here in like the 4 inches or 10 centimeter, and same thing down here, so 4 inches, 10 centimeter. Now I'm getting some muscle. So at those points, those 2 points, I'm also looking at atrophy or hypertrophy. Just kind of an addendum to what we're talking about here. I'm always, though, going to measure at mid patella because mid patella gives me a girth measurement of the joint line, of how the joint itself looks. So I always technically want to measure that. Like even if I was doing like the shoulder, I'd always want to kind of measure mid shoulder as well. If I was measuring the elbow, I want to measure it mid elbow because that gives me my joint line measurements. And you would measure both sides. Why? Why would I want to measure both sides? Comparison, right? Just looking at this, here's her right knee and here's her left knee. You can see that right is 40, 38, 42. She's definitely a little swollen above and below that joint line. Right? Not horribly. She's a little swollen. All right. So for this semester, while it's important, this function and transfers and stuff like that are important, but it kind of gives you the ability to tell how safe she is. And this is really important to understand. So it says, patient is seated at edge of bed, edge of mat, independently with both dynamic and static balance testing, as long as she has 2 hands down. So what does that mean? Could you leave this patient at the edge of the bed and go get equipment? Yeah.
Yeah.
Yeah, because she's independent. She's most of the way, she can do most of her stuff. You know, she can sit there as long as she has both her hands on the mat, she's safe. Right? If it says something like mod assist, would I want to leave her by herself? No. right? At that point, I want to either lay her back down on the mat or I want to put her in a wheelchair where she's going to be safer, or a chair with arms, something where she's not going to just fall out of the chair, right? But despite the fact that she's independent, we are still going to put a what on her?
Gate belt.
Okay.
Gate belt. Yeah, right. So if we were actually doing this practical for real, when I come in and I'm coming in to introduce myself, I'm like, hi, my name's Keith. I'm going to be your physical therapist assistant for the day. Today, we're going to do some knee exercises, some knee measurements, and stuff like that, just like you did last time with your glorious physical therapist. I'm going to go ahead and put this gate belt on you while we're kind of going through some things. And as I'm talking to her, I'm putting that gate belt on her right away. Today, how's your knee feeling? Is there any pain today? Right? I'm just going through my normal stuff. But as I'm doing that, I'm cinching that gate belt on her to make sure I don't forget a gate belt. Transfers. Transfers, it says bed mobility, supine to sit. She's standby assist. What does standby assist mean? SBA.
We're just giving them like verbal cues or being near in case they need assistance.
Yeah. So where are our hands on the patient?
No.
No.
For standby assist, right? We're not there. We're not on. We're just kind of there, right? Independent, we're definitely not hands on with them, right? But standby assist, we're just there if they need us. But for the most part, we're like, okay, good. Use that leg lifter, right? She's able to move around in bed, mod I, meaning mod I means modified independent because she uses a leg lifter. The only way she'd ever be able to say she's independent with bed mobility is she gets rid of that leg lifter. So what is a leg lifter? Because that's going to be the next question, because I'm sure that somebody in here, maybe Danielle or somebody's going, well, what's a leg lifter, Mr. McKeever? Does anyone know what a leg lifter is?
Is it like something that goes under your leg and has like a pulley system for
Yeah.
you to like lift up with your upper extremity?
Yeah, that's a more expensive one. Yeah,
Hmm.
right. There are those.
Like a wedge?
Nope. A leg lifter. So I don't know if any of you guys are old enough to remember this. I don't think so. But back in the day when I grew up, we had these things called invisible dogs. And an invisible dog was this, it looked like a leash. It was a straight leash that was solid. And at the end, it had this ring that looked like a dog collar. Back in my day, exactly. And what it was you could walk around pushing this stupid little thing in front of you, and you had an invisible dog with you. Right? These were the kids that didn't have pets. Well, somebody realized, well, that invisible dog, so basically, it looked kind of like this. Most of them are blue in therapy. It's this blue device with a loop on the end of it. And up here, it's got a handle that you can wrap around your wrist. This whole thing is rigid. So it's kind of like stick-like. But you can take that loop it around your foot, pull on it, and use that to lift your leg. So somebody realized, sometime around the mid-90s, hey, I can repurpose all these invisible dogs that no one used anymore as leg lifters. And they made another $1 million. But the leg lifter is just a device to help them lift the leg. You could just as easily use a belt or a towel. It's just to help her move that leg out of bed when she can't actively function with that leg. The leg's not strong enough to lift it itself. She's using her hand to help move that leg.
Are you talking about like just help like swinging it out?
Yeah,
Out of the bed?
Yeah, so where's my gate belt? Hold on here. Let me grab my gate belt. So basically what a leg lifter is going to do is it's going to go around her foot like that. And it's going to allow her to lift that leg so when she gets out of bed, she can swing it out of the bed. Or when she gets back into bed, she can use that, lift it up, help scoot herself back into bed when she doesn't have the strength to lift that leg. Does that make sense?
Yeah, it makes sense. I was kind of having a hard time just picturing it. That's why
I
thank
grabbed
you.
it to kind of demonstrate, right? So I can lift the leg up like this, right? Now I can also use this leg lifter when I'm doing heel slides, right? I could use that to help facilitate heel slides as well. So it's not only useful for leg lifting, but it can be used kind of as a therapy device later too.
That's perfect. Thank you.
Yep, no problem. All right, so we got the leg lifter explained. That's okay. That's why I want to cover these. She transfers from sit to stand with standby assist again, and she gets up to a standard walker. Now, one thing to remember about a standard walker is, can you have normalized gait with a standard walker?
No,
No, why?
because you're kind of bent over.
Okay, well, that hopefully not if we fix it right.
You can't extend your legs as far as you normally would.
You could, right? And the other thing is you have to pick that walker up, right? In order to walk, you have to constantly be picking that walker up. That's not normal gait, right? Normal gait's your arms are swinging, right? If I have a rolling walker, I can kind of, because the walker's just going to move with me. I don't have to pick it up. So she's able to walk about 30 feet by one, minimal assist with the standard walker, meaning we're there. How much assistance do we give with minimal assist?
25%.
How much did you say? I'm sorry, Truman.
25%.
25% or there's a key thing for that. 25% or less. Does that make sense? So 15 would be okay. So this would be one where minimal assist means we, if I'm going to put this we, PTA, them, the patient. So if we're doing minimal assist, we are doing less than or equal to 25% of the work. Does that make sense?
You said that's for min assist?
For minimal assist, yes. That's from our perspective. Now for the patient, that means how much are they doing?
Oh, 75 or more.
Yeah, so they're doing greater than or equal to 75%. Yeah. I wanted to hit that specifically because your questions on your boards are going to be asking in both ways. So they may say, you are providing the patient with X amount of assistance with a minimal assist patient. Or they may say, you're providing the patient with 15% of assistance. This would be classified as, that would be min assist. So you have to read when you're reading your questions on your boards, are they talking about how much work you're doing or how much work they are doing? And then you have to translate it. Does that make sense?
Yeah.
They're very tricksy about that. Right? So that's min assist. We'll hit this real quick before we go any further. What's the next level up?
Moderate assist.
Mod assist. Good. Mod A, right? Okay. Mod A is what? Let's see what Dr. Soka taught you guys.
50%?
Okay, 50. Anyone have a percentage like more than or less than? Anyone have a guess? Typically, they say that we are providing it at that point. So the patient is doing somewhere between 25 and 75% of the work. That means we're providing the opposite of that. So they're able to do somewhere between 25 and 75% of the work. And actually, because if they're doing more than 75, they're a min assist. Technically, I guess I should call this 74.9. Not that we measure that anyway, but so they're doing somewhere between 74% and 25% of the work. If they do less than or equal to 25% of the work, now what are they?
Max.
Max. Yeah, at that point, they're a max. Now, some of the books will say if they're doing less than 5%, they're technically dependent. But dependent for me means they're not doing any of the work, right? So if they're doing 0% of the work, they're dependent. That's it. That's not a B. Mr. McKeeper can write. I just realized how much that looked like a B. That is a D, dependent assist. Right? So at dependent assist, how much work are we doing? We are doing 100%. At max assist, we're doing greater than or equal to 75% of the work. And so in this range here, we're doing somewhere to more than 25% to about 70%, 74% of the work, depending upon the patient. So mod is our biggest range. Let me ask you a question about this. So let's say John is working with Anthony, and Anthony's his patient. And Anthony, it feels like he's doing 25% of the work, but maybe he's not doing a full 25% of the work. And John's not sure if he should label him as a mod assist or a minimal assist. What do you think for notes you should do? First of all, good. Yep.
Good.
Nope.
Well, I was gonna say min, so it could give us more area for progression.
Okay, it shows that they're progressing more, right? Yeah. The main thing I would say there is look at what your previous note said and go with that. So if last time they were a mod assist, stick with the same, right? But that's when you look at it going, okay, I've got to really kind of gauge this on what they're doing, because if I say they're a min assist, they've gone from mod to min, maybe insurance is going to cut back some of my visits. So you have to be real careful when you make those progressions. Just be looking at it going, were they really doing 75% of the work, or were they doing 70% of the work? Does that make sense?
And that's even if, like, let's say another PTA saw them, or the PT saw them, you know, just kind of go off of that.
Yeah, I would go off of that. But the other thing is it's possible that you could have seen Anthony yesterday. And yesterday, Anthony was on meds and he was a min assist because the meds helped handle his pain. And now today he's a mod assist. Yeah, definitely you want to indicate that today he's a mod assist. He's heavier. He's a lot more work. Does that make sense?
Mm-hmm. Yeah.
So it just depends. There is a subjectiveness to this is kind of what I'm saying, right? It's not 100% objective.
Makes sense.
Would you say that he was, because of the medication, it was slightly different, or
Yeah.
would you not add that into it?
No, I would. I might assess that and say that, patient reported having, or, not patient indicated, noted that patient had more difficulty today due to lack of meds. Does that make sense? Because if I say patient indicated, that's really subjective because that's what they said. You got to be careful when you do that type of stuff. Right? But I could say noted or noticed that patient had more difficulty today with movement because did not have meds today. And we may be doing that intentionally. We may actually be seeing how they do without meds to see how they'll do if they don't have meds too, right? That could be a possibility. Does the assistance level make sense? If they're a dependent assist, how should we be getting them out of bed? What would be the best way? Two people ideal. Well, I mean, 2 people would be the best, Riley said, but the better than that would be getting a lift. If they're dependent, get a lift. Yeah. Why do I say that? Just because of safety, right? Even if you have 2 people, even if you have 3 people, when you're transferring somebody that's a complete dependent, meaning they can't do anything, you are putting yourself at risk for injury. It is better to err on the side of caution and get a lift. Now, what if your hospital doesn't have a lift? Well, then get help. I would suggest, and it's just personally, I would not suggest moving a dependent patient by yourself, especially as a new grad or especially as a student, just because there's too many variables that could go wrong, right? When you have a dependent, get some help. Right? And it's okay to ask your CI to say, hey, can I get some help here real quick? Right? Now, if you're the person moving them, you've got to tell them what you want them to do. Don't expect them to just do it. Right? If Riley's the clinician and she's moving me and say Amanda is her CI, that would be a time where Riley said, hey, we need to get Mr. McKeever out of bed. He is a dependent. Can I have you make sure that the wheelchair doesn't move for me when I get him out of bed? Now I know, or now Amanda knows exactly what her job is. Right? And she's like, okay, good. You're going to do most of the work and I'm just going to make sure that that wheelchair doesn't move for you. That's taking a step further, but I just kind of wanted to hit that. Does that make sense? All right. Well, I went way too far into that and more than I needed to, but I just wanted to make sure you guys had that in your head. All right, patient is using a 3-point step 2 gait pattern. Uh-oh. Now we got to review the gait patterns. How many of you guys remember all your gait patterns? Does anyone remember them all? Somewhat? Do we need a demonstration of them?
Yes.
Works like, yes, I give up. I quit. All right, hold on. Let Mr. McKeever find some fake assistive devices real quick. All right, I have some fake assistive devices. Let me change my video. Do you want me to make this big screen for you guys and just get out of the
Yes.
thing for now? Okay, so I'll stop sharing for right now. All right, let me just adjust this video so I can get a little bit better shot. Get a little bit more floor space here. All right, so there is no judging that I'm using a mop, please. I don't have crutches in my house. All right. So, stupid mop. See, this is why I said no judging. All right. So what are the gait patterns? Let's go through all the gait patterns. We have, what's the first gait pattern?
2.2.
How many? Okay, let's start with the most points first.
Oh, 4.
4 point. Okay, so we have 4 point. Let's say my right leg is my bad leg. Right, so this is my bad leg. With 4 point gait pattern, does anyone remember how the 4 point gait pattern works? Just give me a quick overview.
I think you move the I don't know if it's the left or the right arm first.
Okay,
I think it's a right.
okay,
So you move your arm with the assistive device.
okay,
You move your left leg forward,
okay.
and then you move the left arm with the assistive device forward, and then the right leg.
Good. I mean, so here's the deal. As far as starting, doesn't really matter. So don't totally get lost on which one to start with. The questions are never really going to ask you that. So it doesn't matter if I start with this leg or this crutch, or if I start with this crutch. Just know you're going to start with one of your assistive devices, and then opposite leg, there, there. So it's going to go crutch, leg, crutch, leg.
Even if your right lower extremity is the bad one, you would start with the left.
So that's kind of what I'm getting at, John, is once I get going, doesn't really matter.
Oh, okay.
Yeah, that's what I'm kind of, I typically will start them with this crutch, because that way when I plant forward, I'm bringing this crutch up here. Now I've got support, double support with that leg. Does that make sense? And I can bring through, but it really doesn't matter, because once I get moving, it's just crutch leg, crutch leg, crutch leg, crutch leg. Does that make sense?
Yeah, that makes sense. Thank you.
So some books will say this way. That's not wrong. It's just not the way I've done it throughout my career. So again, 4 point, I have to have, first of all, 2 assistive devices. We're going to pretend that these are, I don't know, loft strand crutches. I have no idea. So crutch, leg, crutch, leg. Now, real quick question. Is that a fast or a slow gait pattern?
Slow.
Slow, right? Also, is that a cognitive or non-cognitive gait pattern?
Cognitive,
Why?
because you have to think about which step first.
Yes, I can't see my head nodding, but yes, right? There's so much going on, right? So if you've got somebody like, say I have a TBI, this may not be a good gait pattern. Does that make sense? Because man, if I've got a TBI and my brain's messed up and you're like, crutch leg, I'm like, oh, what? All right, so that's 4-point gait pattern. Does that make sense for everybody? That's 4. 4. Now let's go to the one John wanted to do, 2-point gait pattern. What is 2-point gait pattern? Somebody take a shot at it.
It's like, I think that's the one where it's like skiing.
Okay.
I think
Yeah.
you put both the assistive device and the lower extremity together.
Okay.
So your right leg and then the right upper extremity with the assistive device together.
You're close.
The left upper extremity.
Good, right? So it's opposite,
Oh, okay.
right? This is like cross-country skiing. If any of you have ever cross-country skied, this is the way you cross-country ski, isn't it?
I've done that, so maybe that's
That's okay. That's why this is helpful. This should be helpful, I'm hoping. All right, so if my right leg is my bad leg, right? Shake it all around. I typically, again, this is me, but not necessarily a necessity. I typically start with that leg. So I'll go right crutch or left crutch, right leg. Boom. 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 It's also the pattern you use if you're hiking through the woods and have dual hiking poles. Right? So it doesn't matter which leg I start with, as long as I'm moving them opposite or reciprocal. Does that make sense?
yes.
Now that pattern is fast, right? I can get moving pretty quick with that pattern. So that's a really good pattern to teach patients, especially here in Las Vegas, because it'll be useful for getting across the street. Because think about it, if I've got to do 4-point gait pattern to cross Flamingo Road, smash, I'm dead. Right? We gotta get halfway, like a quarter of the way across, they're just gonna plow me over.
I
So
feel like that's
2-point
how
Yeah, go.
everybody crosses the road. I feel like that's how everyone crosses the road anyways.
Yeah, even if they have 2-point, they're like,
Yeah, well, even without any points, healthy
Without any
people
points,
cross the
right.
road like that.
I would tend to agree. All right, so 4-point, crutch, leg, 2-point, crutch and leg, crutch and leg. So far, okay.
Yeah.
Okay. And while on the phone, exactly, Diana. And what I really hate is people that are on the phone walking, carrying it like this, talking, screaming into it. Anyway. All right, so we've done 4, we've done 2, let's do 3. When you think of 3-point gait pattern, I want you to think of non-weight bearing. Non-weight bearing. Okay? So if I'm non-weight bearing, that means that this right leg is going to be up in the air because I can't put any weight down on it.
Would this mainly be the auxiliary crutches?
This could be auxiliary. Yeah, I could have axillary crutches. I could also have those loft strands, the ones that go on my forearms, technically. I could have a walker too, right? If I had a standard walker, I could do a 3-point as well, because I could just move that walker forward, right?
Okay.
3-point just means I'm not putting any weight on this foot. This is my bad foot, I can't put any weight on. All right. So 3-point means I go assistive devices, boing, right? That's your typical crutch pattern. That's that one you think of, right? Now remember, with this pattern, there are 2 different parts of it. You can either have step 2 or swing through. Step 2 is where if I'm non-weight bearing, I put the crutches here, I hop to them. Right? And then I put the crutches out and then I hop to them. What does swing through mean? Does anyone remember?
You go past your PT.
Right. Yeah, I don't know if I can do that with these. So I put my crutches out here and I go through them. Right? So I'm going to end up out here. And then I'm going to put the crutches out and then I'm going to take a little bit farther through. Probably better suited for an athlete, right? Not necessarily good for every person. All right, so 4-point, crutch, leg, 2-point, crutch and leg, crutch and leg. 3-point, non-weight bearing, crutches, then good leg. Are we okay so far?
Yeah.
All right. So now we get down to the modified patterns. Because we have what's called 3-1 or modified 3, modified 2, and modified 4. So let's start with the 3-1 pattern first. So if 3-point pattern is non-weight bearing, 3-point pattern is partial weight bearing. 3-1 is partial weight bearing. So I'm able to put a little bit of weight on that foot. In that case, that's where I take both crutches and the leg, I move them forward together, and then bring my good leg. That's the 3-1 or modified 3-point. This is really annoying me. I'm gonna bring crutches home.
You said that modified 3-point?
Modified 3 or 3-1 are the two names for it,
Okay.
right? So I'm modifying the original 3-point pattern. Does that make sense? Or the other way I think of this one is 3 legs, 1 leg, 3 legs, 1 leg.
But you always go with the bad lower extremity,
The
correct?
crutches always go with the bad lower extremity, yes, because they're going to provide support.
Support. Okay,
So I'm not putting all my weight through that foot.
that makes sense. Thank you.
All right, so just to go recap again, 4-point, crutch, leg, good. 2-point, crutch and leg, crutch and leg, crutch and leg. 3-point, non-weight bearing, boing, boinga. And then modified 3 or 3-1, crutches and affected leg, good leg. Crutches and affected leg, good leg. Yeah, modifying it to toe touch or partial weight bearing band, yes. All right, so we only have 2 more patterns really to go over. And that is modified 4 and modified 2. Does anyone remember what happens with those patterns? Okay, so the modified pattern for 2, and so for the modified 2 and the modified 4, I get rid of one of my assisted devices. There you go, it's gonna happen. So I go down to only 1. Actually, I'm gonna use this one because the mop keeps falling apart on me. Right, so now I'm down to 1 assisted device. So a modified 4-point pattern. Assisted device, bad leg, good leg. Assisted device, bad leg, good leg. That would just be like when I did boom, 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 boom. I just don't have this boom over here anymore. So crutch, leg, leg. Crutch, leg, leg. That is the modified 4-point pattern. Then our last pattern, which is the modified 2-point, is your typical cane pattern. It's the one you usually see old people walking with. So if this is my bad leg, it's my assisted device and my leg, and then my good leg. That is the pattern House should have been walking with. But unfortunately, he had the crutch on the wrong side, or the cane on the wrong side.
Wait, what?
Yeah.
What's the biggest difference with mod 2 and mod 4?
So, okay. So let's just go back to 4-point really quick, 4 and 2-point, right? So 4-point, just
Oh yes. Okay.
crutch, leg, right? So yes, exactly. With modified 4, I now only have 1 assisted device, crutch, leg, and leg, because I don't have this device anymore. So that's modified 4. And then for 2-point pattern, I go crutch and leg, crutch and leg. For modified 2-point, I go down to 1 assisted device again. God dang it, I'm gonna trip on that watch. crutch and leg, scepter. Is modified 4-point and the 3-point the same? No. Joe, so it's good leg always stays back. It just depends. Really, once you get going, Joe, it doesn't matter. Typically, yes, Anthony. So Anthony has bad leg always goes left, the good assist, right? Typically. So let me get back to, I think it was Bianca that asked. So remember, 3-point pattern is non-weight bearing. So 3-point, I've got this leg up in the air here, hopping to my assisted devices. Does that make sense? Right? And then 4-point is boom, 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 boom. For a modified 4, I get rid of 1. Your crutch always goes on your good side. So it should be good, good, bad. Crutch, leg, leg, crutch, leg, leg. Yeah, don't think of as many touches. That will mess you up. You just have to remember the patterns. Honestly, Bianca, if you start counting the points touching the ground, it'll really mess you up. We really need to come up with better names for them, to be 100% honest. Right? That's why when I think 3-point, I think non-weight bearing. Do we need me to go over them again, or how's that?
So for 2 and 4, when you're modifying, you're just taking away one of the bad side, correct? And you're
Yeah, take
keeping
away the bad side of things. The bad side assisted device.
Okay, I got it. Thanks.
Yep. Was that helpful?
Yes.
Okay, good. Now I'm going to have a mop and a Swiffer handle in the background for the rest of the video. It's amazing what you can get away with when you're doing stuff at home. Okay. So let's think about the standard walker just real quick, because this ties into the gait patterns. I can do 3-point with the standard walker. I can do modified 3-point with the standard walker, because I could do the walker in the leg, good leg, walker in the leg, and the good leg. Is it really possible for me to do 2 or 4-point pattern with the standard walker? No. Right? Because the walker doesn't do that. Now, there are some walkers that are called reciprocal walkers that allow that. But those are, I don't like them. They're stupid. They're dummy-headed walkers. No, don't use them.
When you're treating a patient and say you're trying to have them walk around the whole facility on the standard walker,
Mhm.
and they're doing a 4-point pattern walker, do you have to document that?
Well, with the walker, they wouldn't be able to do 4-point.
You just said was it 4 or 2 when you're like
2-point.
doing the
We can do 3-point with the walker. So 3-point. So
Okay.
the 2 that I could do with the walker are either the one with the legs up in the air with the walker and hop into it,
Okay, so the
or I
2.
could do step with the walker and move the walker at the same time with the foot. Those are the only 2 I can really do with the standard walker.
So a 2-point, right?
3 or
With the-
modified 3.
Okay.
Does that make sense?
Yeah, sorry, I was just thinking about something, but
Don't think about the number of points down. Again, don't get lost in that. Because
Okay.
otherwise, would Christina know what? Oh, no, that was the answer to my question. Never mind. You're right. Okay, sorry. Whew. So I'm like, no, Mr. McKeever. I was really confused. I'm like, she's telling me no? What did I do wrong now? I mean, the only reason I say that is because I think you're going to go over this more sleep. No more sleep. I think you're going to go over this with Dr. Sokel maybe next week as well. So I just want to make sure you guys got the patterns down pretty well. The standard walker, you can really only do 3-point and 3-1. That's it. With the rolling walker, you can do standard, like normal gait pattern, because the walker rolls along, where you're just going heel, toe, heel, toe, heel, toe, heel, toe. You could do a 3-point pattern, but man, I don't know that I'd want wheels doing that 3-point pattern, because I can imagine that you jump to that walker and that walker just shoots out from under you. Or you can do 3-1, where you move the walker and that foot together and step to it. You really can't do 2 in the 4-point pattern until you get down to like crutches or canes or loft strands, because you have to have 2 devices. Cool. All right. Well, you guys, at least I'm happy you guys had 2 and 4-point pretty well. Good job, guys. I'm happy for that. That's a step in the right direction. All right, so she is walking with a 3-point step 2 pattern, meaning she can't weight bear on that leg. She also displays reduced balance with the right side lean. So she tends to lean to that good side, probably because she's off balance. So we have to work on that balance a little bit. So patient is unable to ascend or descend stairs and uses a freight elevator in the apartment to get to the 2nd floor. That's not very independent. Why is that not
Mr.
very independent?
Sorry, Mr. McKeever, you're
Yep.
not sharing the thing.
Oh, I'm sorry. Thank you.
All right, thank you.
Your speaker just went out, Mr. McKeever.
Your mic.
We don't know sign language, sorry. Just kidding.
All right,
Nice.
Jordan, teach the class.
Am I back now?
Yes.
All right, there we go. It sometimes happens when because I've got so many. That's okay, I'll cut it out, John, don't worry. Sometimes happens when I switch cameras a lot that it kind of jostles between them, and then it's just because Zoom's not very smart. That's just what it is. All right, so I can hear me now. You can hear me now. Anyway, so it says the patient is unable to go up and down stairs. Why is that not very functional?
Because she can't get up to her home.
Right, so she had an elevator to go up and down, but what's a problem?
Well, if the elevator is not going to work, then she won't be able to go up and down.
Yeah, so what happens if there's a fire?
She's,
Right?
The jump up.
She's gonna jump, yeah. She just dies. She has to get on the railing and just kind of do the skateboard slide down it, right? I'll break a hip, but at least I'm alive. But yeah, so that's why it's not very functional. So right now it's okay, she's got that, but she's not a very functional person at this point because she can't get in and out of her house very functionally. So this is important to look at what the patient's goals are. What does she want to do? Well, she wants to be able to walk without using that walker, without the assistive device. She wants to get back to sewing, laundry, and cooking. And she wants to get back to volunteering at a nearby soup kitchen. Why is that important? Well, when you're talking to her, those can be useful things to get her to do the things you want her to do. Look, if we don't get this better, you can't get back to doing this. Right? If you don't do these things, you don't work on going up and down stairs, we can't get you to up and down the stairs to do your laundry. Right? So you kind of have to tie those together. That's a little more advanced than this type of scenario, but that's just kind of the way that you use their own goals against them is what I'm saying. Use the force loop. All right, short-term goals. Not really a big deal here. Again, for this one, for this practical when we had this, and even right now, this just tells you what the PT wants to do. But in reality, we're not going for these short-term goals. We just want to be able to do what's on the flow sheet. So don't really worry about it. You can read through it, but not a huge, oh my God, I've got to know these inside and out. Same thing with CPT codes. What are CPT codes?
Insurance.
Yeah, it's what we can bill for. Yeah, right? So the PT has given us as a PTA what we're allowed to bill for. Some of it's Therex, some of it's gait, some of it's manual therapy. Like current. It's current procedural terminology. Right, and it's CPT 10 right now. We're in the 10th generation of it. I think.
I'm guessing that's pretty standard for.
Oh, what these CPT codes for this patient? Yeah, those are pretty much the standard ones, right?
Okay.
Like laser's not on there, ultrasound's not on there. But if we wanted that, we could talk to the PT, right? Maybe you're like, maybe John's like, hey, I think we could do some ultrasound, loosen up that hamstring a little bit to get her better with that knee extension. Well, then he'd have to go talk to Dr. Reskin and say, hey, could we try ultrasound next session? And Dr. Reskin could go and add that CPT code for him. Does that make
So-
sense?
Make sure we don't have to memorize the CPT code.
Not yet.
That's for the PT.
Well, no, you will eventually have to know them, Brooke, but not yet.
Okay.
Because you have to know, so as a PTA, you have to know if the PT puts 97010, you have to know what it means. You have to know that that means, does anyone know what 97010 is? Okay. Gate. Which one's Therex? Anyone know which one's Therex is?
I thought that was Terex.
It is Therex, yeah. Right? Does anyone know which one? Manual therapy. I think manual therapy is 97140, if I remember correctly. Again, I don't deal with these, so I have to study them before I teach you these in 5th semester. So see, I have to teach. All right, so here's the important thing. This is the flow sheet. All right. So, well, I got to change the date on this because that was the last time I modified it. She hasn't been seen for a while. I think she needs a re-eval. What do you think, Raquel? We're just going to pretend that doesn't say 12-4. We're going to pretend that actually, let's say that says 7-17. Yeah, we'll just pretend that it says that. All right, so if you were doing this in the clinic, you would come down here and see what you're going to do. So this tells you you're going to take goniometry measurements. You're going to take manual muscle testing. You're going to do girth measurements. And then you're going to walk with the assisted device. Not that bad, right? That's not horrible. How many of you feel like you could actually do this patient? Or at least fake your way through it? Don't I feel like I could fake their way through it?
I feel like I can fake my way through it.
Okay, yeah, right? Yeah, this isn't that bad. Okay, so let's start with goniometry. That's fine, fake it, till you make it, buddy. That's what I do it. Let's start with goniometry. We're gonna measure knee flexion and extension. Let's start with landmarks. What are my 3 landmarks for measuring knee flexion and extension?
Your lateral condyle.
Lateral condyle is my vertex, good.
Then your mid patella.
Not
Oh,
mid
not mid
patella.
patella, sorry.
Mid
Mid femur.
femur, good, right? Using what is my distal landmark endpoint?
Your lateral
Lateral malleolus down there. What about up here in the proximal then?
Oh, greater trochanter.
Greater troch, right? So my 3 points for goniometry, right, would be greater troch, lateral epi, lateral oh my God, malleolus. There we go. My brain fried. That's it. What position to measure extension and flexion of the knee?
Supine and extension.
Supine for both.
Oh, yeah.
Remember, because I said supine for the knee flexion because they bring their foot up like this, right? We're not going to, we typically don't measure knee flexion in prone. We measure manual muscle testing in prone, but we don't measure the actual goniometry in prone. So supine for both.
Would you be able to you wouldn't be able to like multitask, or it's not when you're doing like manual muscle testing and then goniometry?
Yeah, I mean,
Like-
you mean back them back to back? Sure.
Yeah, for like knee flexion.
Yeah,
Would you do that?
you could if you're skilled. Yeah, I wouldn't do it right off the bat,
Sure. Okay.
right? But yeah, absolutely. I mean, can I take goniometry in prone? Sure, I can. I've done it enough. Right? Now, the book says, by the book, for your testing, it's in
Mhm.
supine. But sure, I could actually manual muscle test him in super and prone and then just go right in and get my goniometry in prone too. Sure. right? I could do it seated technically if I really wanted to, right? Again, in the clinic, not as rigid as what your book would say, right?
Makes sense.
Okay,
Thank
so we know that patient's in supine for this, right? So supine, I'm not writing this in here to fill this out. I'm just saying we got supine, we've got greater troch, we've got lat epi, and we had our lateral malleolus, right? And we just measure both of them. All right, what position for, I think I've hinted at this, what position for manual muscle testing knee flexion?
Prone.
Prone, good, right? Good. Right, we're gonna have them prone, we're gonna have them kick up towards their butt, and we're gonna push down and tell them not to let us push them down, right? Good. Now, here's the thing, because this is important to understand. This patient's already up to a 2+ now in the second visit. Should we always start them with gravity? Nod your heads, yes, please.
Yeah.
Yeah, we always want to
Yeah.
give them the chance to go against gravity. Does that make sense? Even if they fail miserably, give them a chance.
So always start at 3 then.
Always
right?
start at a 3. Always start at a 3.
Okay.
Yep. Even if they're a 1, give them a chance. Who knows? They might improve. Right. And then also, like you said, I could be doubling up on some of my stuff too, John, at that point. All right. So what about knee extension? What position? For manual muscle testing.
Short sitting.
Good. Short sitting, right? What are we going to be doing? What type of an exercise? They're kicking the leg up.
Leg extension.
Yeah, leg extension, or otherwise known as a
Straight leg lift.
not straight leg lift, long arc quad,
Oh,
Long arc quad, yeah.
right? You're kicking up, boom, boom. But also remember, with that one, don't let them lock that knee out before you manual muscle test them, because they can get that screw home mechanism locked in. And they're like, yeah, I'm strong. And then you get them unlocked and like, whoop. Right? So test them kind of like at a 45, right? So if I'm kicking up, I'm not going to test them all the way locked out. I'm going to test them kind of like here. Does that make sense? So they can't cheat and get that screw home locked in. Here you guys, I'm going home. All right. Girth measurements. We already talked about that. How many of you guys feel that you could probably at least pull out the girth measurements without much trouble?
I feel like I need to go over it again.
Okay, so let me roll up my good old knee here.
Well, like I know like the landmarks and stuff. I
Okay.
just like the whole procedure itself. I feel
Well,
like
we're
I
gonna
would need
practice
to
that.
do
Don't
it.
worry, that's what we're gonna do it. Need a marker, right? So if I'm doing this, do I have a marker? Oh, I got my dry erase markers here. All right, so when I'm doing this, right, I'm gonna come down here. There's the bottom part, that's the apex of my patella. So I'm gonna put a mark there. I'm gonna come up here, find the superior part of my patella. Put a mark there. You see the 2 marks? Right? And then my little bear rat. There he is. I showed you guys my tape measure, right? Isn't he cute? I'm gonna go between those 2 marks. So my patella is 3 inches. Now I'd have to have my leg straight. I just have it up so that you can see it. So my patella is 3 inches. So where would mid patella be?
1.5.
1.5. So I'm going to find my 1.5. And what I do usually at that point is I'm going to go, okay, so there's 1.5. I'm putting an X, because that tells me where to measure. Does that make sense? So that's my mid patella. And then I've got to go 4 centimeters down from mid patella. So 4 centimeters down. There's my X for that. And then I'm going to go 4 centimeters up. There's my X for that. So now I've got my marks. And I just take my goniometer and I go around each of those marks and measure it. I know that was a really quick and dirty way. But does that
Repeat
make
it.
sense?
I thought it was 5 centimeters, like 2
Oh,
inches.
yeah, let's say 5 centimeters. So then, thank you.
Oh, I was about to ask that too.
Yeah, I can't read.
Please.
I'm from mid Pennsylvania. I can't read. I'm just kidding. Yeah, it's 5 centimeters. Thank you. I had a question. Who had a question? I heard a voice. Or am I hearing things?
No, I just remembered it was 2 inches too.
Yeah. 5 centimeters, 2 inches. You're right. I messed that up. You're correct. Good calling me out. I was testing you guys, see if you're paying attention. Didn't totally screw that up at all. Well, you know what I would do at that point? That's where you take the good old alcohol wipe and you start wiping that off and remeasure. That's okay. It happens. Right? It happens all the time. Honestly, I've screwed that up before. But you got your 10 PPS points back. There we go. We'll give them back to John so he doesn't fail. All right. But yeah, with a little practice, you could probably fake your way through that one, right? That one's not that bad. All right. So last one then is gait. You're just going to go through and walk with them. So you're going to have the gait belt on them. Your min assist, is your hand going to be on the gait belt at all times with the min assist?
Yes.
Yes.
Yep.
Right. So remember, this is an important thing to understand. As soon as your hand is on that gait belt, that is a min assist according to Medicare. So as soon as you've got that hand on that gait belt, you're providing them with minimal assist according to Medicare. Where should your hand be for contact guard assist?
Shoulder.
Shoulder, mid back, somewhere that's not the gait belt. So if I've got this gait belt around me, uh-oh, I think I made that Bianca sized. That's not going to work out very well. Because I'm definitely not Bianca sized. So if I've got this gait belt on me, as soon as I grab a hold of that gait belt, I am a min assist. If I'm working with somebody that's contact guard, I could have my hand up here in their mid back. I could have it up here on their shoulder. A contact guard just indicates you have your contact on them to guard them. Does that make sense? Okay, good. So how do you know how far to walk 25 feet? Because how many of you can estimate 25 feet just by looking? Oh, that's about 25 feet. What do you use to measure? 25 steps might not be a bad idea. Honestly, I use ceiling tiles or floor tiles. Most of the ceiling tiles in our what do you call it, in our school are 2 feet. So you want to go about 12 and a half of those ceiling tiles and then come back 12 and a half. That gives you 25 feet. You see how that works? Right? Or actually, technically, you want to go 6 and a half and 6 and a half, but whatever. Because you're only going 25 feet. But that's how you measure it. The other thing you could do is, Christina said, you could mark off 25 steps. Take 25 steps really quick out, get an estimate of where that's at, and walk them that. That works too. One of the clinicians I work with has one of those little, I don't know if you guys have ever seen them for like measuring when you're doing like making outside land measurements, a little wheel that walks out and determines how far somebody walks. So he walks all of his patients. He doesn't even measure until he's done with them. So he walks as far as they can walk, walks them back, and then you'll see him walking through the hallway with his little measuring tool to see how far the patient walked. Any of those is valid. It's not a perfect science. And then once you kind of do all your work there, so you're going to go down through it. So you knock out your goniometry, you knock out your random muscle testing, you knock out your girth, you knock out your ambulation, you put your name down there, your initials down there, done. SW.
Standard walker.
Standard walker. Yeah. Right. It may also be listed as a 4 PT walker, 4-point walker. It's usually standard walker. One other thing, just in case you guys ever do this, for those of you that are going back to the East Coast, what is this? What is FWW?
Front wheeled walker.
Front wheel walker, right? On the East Coast, we typically just label them as this, RW.
Rolling?
Rolling
Walker?
walker, yeah. So for, I think one or two of you are going to the East Coast for your clinical FLs. You may just see it as an RW. That just means rolling walker. Front wheeled walker is much better of a term. Yeah, it is a good, right? Yeah, so there are some nuances between the coasts, I'm just saying. All right, so if this was your practical, you do all that, and then the next thing you're gonna do is, here was my SOAP note. You could read this if you wanted. But the good news is, if you have the SOAP note, and you have my previous SOAP note, what does that give you a good guide to help write? It helps write your own SOAP note. Could you not just take my SOAP note and pretty much duplicate it? And just put your stuff in? Yeah, absolutely, right? There's no rewriting the wheel here, folks. Now, if you know that I'm a bad SOAP note writer and you follow me, then don't copy my note, right? If you know that, oh my God, that Mr. McKeever writes horrible SOAP notes, I'm not gonna follow, I'm gonna write my own, right? But for sure, if you know that I've got a fairly decent SOAP note, use mine as a guide. And this, I did write this, this is old. I wrote this last 2019, right? So patient agreeable treatment, patient reports 2 out of 10 burning pain on her asset left knee, mid patella, pre and post treatment. Patient reports taking medications 2 hours prior to PT. And then for O, it says see current flow sheet. Yay. When would we have to put something in the O other than that?
If there's any difference.
Good. If we progressed or regressed exercises. Yeah. Right, or discontinued, right, Riley? If we said, well, you know what, we're not going to do measurements anymore because he's at normal measurements now. And then A, we just kind of assess whatever had happened on, right? This one, it looks like the patient had knee pain remained constant pre and post treatment. Patient ambulated a little shorter, right? O is only for progression of exercises, and A, we're going to document why that progression occurred. Does that make sense, Diana? So let's say, going back here, I walked, let's say instead of walking, let's say we added. So we added long arc quads to an exercise, right? So we did 3 sets of 10, 0 pounds, right lower extremity. Then when I come down here to my O, I'm gonna add, come in here and go, and this, again, I'm not gonna add to this because this is the previous note. I'm going to say added long arc quads today. 3 sets of 10, 0 pounds, right lower extremity. Something to that effect, right? You're just going to note that you did. And then I'm going to go down to the A and I'm going to say why I added it. So why would we add long arc quads? What could you put in the A for that? Give me a reason to add long arc quads.
Strengthening
Yeah, good. Strengthening of what? Be a little more specific.
quadriceps.
Yeah, so strengthening of quadriceps, maybe to improve terminal knee extension or something to that effect. Does that make sense?
Yes.
Yeah. Now, if you are handwriting a note, I want to be clear about this. If you are handwriting a note and you have this white space here, you have to kind of scratch out that white space. Why?
So nobody else writes something in there?
Yeah. And even if I'm doing a handwritten note and I put nothing follows, I still come in here and scratch out that white space below. So no one modifies my note. Not even me. Right? Because if I modify my note, I have to do, what's it called if you have to modify your note? Does anyone know?
An addendum or?
An addendum. Yep,
Yeah.
exactly. Right? So I would just create a separate SOAP note sheet that says addendum to previous exercises, neglected to add blah, 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 whatever, and O, right? And just indicate what I needed to add. That's a separate note. Or the other thing I could do is if I know that it's paper and I haven't really submitted this in for insurance or anything like that, I may just crumple this whole sheet up, throw that one away, and write a whole new note if it's handwritten. Or shred it, probably is a better option. Now, at the bottom of all SOAP notes, if you have electronic health records, you will have an auto signature. You do not have to sign. If you're doing handwritten, you do have to sign. Both in your signature and in your print, you have to put your license, which reminds me, I need to renew mine. So I have my license number down there. For you guys, you are going to put SPTA, right? And you don't have a license number, so you don't have to put that. But at all times, you have to put your supervising PT, and they will have to co-sign on your notes, right? That's why Dr. Ovreskin, one of the first things she has you do is go around the clinic and find out who your supervising PT is, doesn't she? So there's a reason for that. Now, could you put, if I was your CI, could you put me down there as your supervising PT?
No, has to be a PT, right?
Yeah, it has to be a PT, exactly. Yeah. So you have to know who, so if I'm your CI, you have to know who my supervising PT is. Does that make sense? So if you're working with me and say it's Dr. O'Neill is my supervising PT, you would put her down as your supervising PT, not me. I'm still going to co-sign in your notes as your CI, but I'm not your supervising PT, I'm just your CI. Does that make sense?
Yeah, so, but it's okay, so only the CI can, or do both the CI and the supervising PT have to co-sign or just the CI?
Yeah, honestly, in most electronic health records, so I'm going to be honest, almost never do my PTs look at my notes. They just usually click co-sign and be done with it because they're comfortable with me, right? Sometimes if I've got a student, they will check my notes just to make sure the student didn't screw something up. But that's my job to make sure your note is okay, not theirs. Does that make sense?
Makes sense.
Yeah, so I will co-sign it and they will co-sign it because they have to co-sign all my notes anyway. So technically, if you're an extender of me, they've got to co-sign your notes too.
For sure. Thank you.
Yeah. Was this helpful? To actually look at a patient, right? Good. I thought this would be. So now what we're going to do on Thursday with this, because we have this patient and we have, so group one is going to have a little bit of kind of work cut out for them. What I would want, what we're going to do Thursday with this is, again, we're going to break up into 4 groups. I'm actually probably going to give group one a different patient since we kind of already went over this, because I've got a couple spare patients. Sorry, group one, you don't know who you are yet, but that's okay. When you find out who group one is. What I kind of want when we get into our groups is we're going to, and we have the ability, I don't think, have you guys done breakout rooms with Dr. Ovreskin before? Yeah, okay, good. So I'm going to break you guys out into your 4 rooms. You guys are going to be as a group. So if there's 4, there's probably going to be, what, about 5 of you to a group or something to that effect. You're going to look at the scenario that you're given. So maybe patient 1, patient 2, patient 3, patient 4, whatever it is. And you're going to talk through it. And I'm going to give you guys a little while, probably about 45 minutes to talk through it. I'm going to be bouncing room to room. So I'm going to go from group 1 to group 2 and just kind of answer questions as need be. And then we're going to come back together as a whole class. And let's say that group 1 was Riley, Anthony, Bianca, and Brittany. And I'm not going to divide it up by alphabet, trust me. I'm going to make it much more fun than that. But then that group's going to come back and kind of talk about how they would treat this patient to the whole class. So, maybe Anthony says, so when we're doing goniometry, we'd have this patient in supine. Here's our landmarks for the goniometry. We're going to measure it up. Normal ranges for the knee are X, Y, and Z, right? So this patient has blah, 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 right? And then maybe, Riley says, so manual muscle testing for knee flexion is in prone. You're going to put them like that. You're going to stabilize the pelvis, push down on the foot. And you're just going to kind of talk through how you would treat this patient. Now, doesn't mean everybody has to talk. I'm not going to be that. I don't like being that type of a instructor where if somebody is not comfortable talking, that you have to talk. I would highly recommend it because some of the best ways you learn is by teaching somebody else. I'm going to be honest. My instructor, when I got my black belt, and he literally on my black belt day, takes my black belt, he hands it to me like this, and he says to me something that stuck with me to this day. He says, here's your black belt. You are now qualified to begin to learn. And I'm like, what the heck do you mean? I just spent 9 years getting my black belt. And then I started instructing. And as soon as I started instructing, I saw all the mistakes I've made. And I really started learning. And it really helped me get a better grasp on what I'm doing. Same thing here, right? I'll be honest. I can't tell you how many bad mistakes or bad techniques I had as a PTA that I have gotten better at because I teach you guys. And because you guys call me out when I measure 4 centimeters versus 5 centimeters. I'm just saying. So that's kind of what we're going to do on Thursday is we're going to break down to those groups and you're going to discuss it. You know, just discuss it and you say how to do, maybe you don't, girth measurement's not on everyone. There may be something else. There may be something like true and apparent leg length measurements. So you may have to look some stuff up. That's why we're going to get in groups so we can look this stuff up. And this kind of gives you the ability to think through a patient as a group. And then when we're back as a group, you know, if say Sydney's presenting something about her patient and Jason has a question, Jason can ask that question, right? But if Sydney doesn't know, I'm still going to be here to answer. It's not like Sydney's on her own. She's by herself flailing around going, oh my God, I don't know that answer. That's what I'm here for too, right? And that's what her rest of her group's there for too. So it's kind of an interactive learning session, something a little different than me just sitting here droning at you for 4 hours since we can't be in lab yet. Does that sound like that might actually be a little fun? Yeah, right? Something a little different. Jason's like, yeah. Jason's like, as long as we don't have to do all the work. So I can tell you for a fact, I am going to get rid of this patient. I will put up a new patient 1. Because we've already kind of went over this patient. I don't want to give some group an easy patient. I've got a couple extra patients I'll put up there for patient 1. But we've got 4 patients, I believe, if I remember correctly. I've got 4 patients up, patients 1 through 4. Just kind of look them over between now and Thursday. There's going to be no assignment. Before I get a hiccup here, before somebody asks me about that. So your assignment for today, tonight, and tomorrow, specifically for those of you that are like, well, what are we doing in the other class? The other class, this is going to be part of your assignment, okay? So I'm going to stop sharing right now so I can get my big fat space back on the screen. And I'm going to stop recording. So that's it for recording.